the alignment. So the recently alignment is very focused on the TKA because now new concept about the TKA is coming. So many different way to do the TKA. Of course, the difference is very small, but the philosophy and policy is quite different. So previously, so it is generally accepted that the implant should be implanted in the perpendicular to the mechanical axis. That was the gold standard. But has been changed in the recently. So this is about the dissatisfaction after TKA. As you know, so around 10 to 20% patients are dissatisfactory after TKA. There are too many reasons. So many reports, including national registry data and many both prospective and then the retrospective study shows that around 20% patients are unsatisfactory. But there are so many reasons to be considered. The one reason is ACL. So cut ACL is necessary in most TKA. So to avoid this in the country, so again, the ACL retaining TKA is focused on. Many surgeons try to do the ACL retaining TKA. But historically, the first TKA is ACL preserving TKA by cruciate retaining ACL TKA. But it's quite difficult to do. Very limited evidence. So a more easy way, more promising way to sacrifice ACL and sacrifice ACL, both ACL and the PCL or standard. But to many surgeons is focused on the very importance of the ACL. So many some surgeons try to retain ACL. For this purpose, currently I prefer to use the UKA if the patient can accept some indication. But some patients have no indication for the UKA because intact ACL, but lateral side is very cartilage is damaged. In such patients, one way is of course normal TKA. Another way is ACL retaining is TKA. And the third way is to the bilateral in compartment arthroplasty. That is another good solution. But anyway, ACL is one reason. Another reason is alignment. Alignment. As I said before, so alignment and morphology and soft tissue is in the same thing. Because in the knee, the soft tissue including LCL, PCL, MCL, LCL, and have to decide both morphology and kinematics. So after the TKA, kinematics should be same as the previous pre-disease condition. But currently, I always use the mechanical alignment TKA. At least mechanical TKA can change the joint line. And because joint line is decided by the function and characteristic of the soft tissue. So if we change the joint line, everything will change, the both stability and mobility, and in the same time the motion of the knee. So we need to reconstruct not only the shape but also the joint line and function. So I should talk about the axis. So this mechanical axis is very important for the TKA. There are two axes. The first one is the femoral axis. It is axis between the knee center. The normal knee center is the top of intercondylar notch, and upper side is the femoral head center. It is quite easy to decide, but this one is sometimes difficult to decide. And another axis is the tibial axis. Normally, tibial axis is from the ankle center to the knee center on the tibia. On the tibial side, the knee center should be the just center between the medial and the lateral tibial eminence. So drawing line from here and here, that should be the tibial axis. So angle between femoral mechanical axis and the tibial mechanical axis, we call it HKA, hip knee ankle angle. So ideally, this angle should be same, zero angle. But it is really only the idea, but very few people fall on this ideal alignment. Yeah, so the most people has the slight varus on the slight valgus, even in the normal patient. So it is only the ideal, but in fact, many patients have the constitutional varus or constitutional valgus alignment. It is a normal. So in other words, so individual patient has individual alignment. So, but we sorry, this is another topic. But this is the tibial side. The tibial side is to decide mechanical axis is quite easy because anatomical axis and mechanical axis are virtually same in the tibial side. But in contrast to the femoral side, in a anatomical axis and mechanical axis is different. Hi, Chanter. Hi, Chanter.
Yes, Professor. Yes.
How do you know the mechanical axis intraoperatively? How do you know?
Yeah. We point to the ESIS. We can see the ESIS during operation.
On the preoperative X-ray.
Preoperative X-ray. We can see by standing view.
Oh.
Yeah.
This one. So, but you need the long X-ray.
Long X-ray, yes.
Yeah, only the short X-ray you can recognize. You can recognize the femoral head center. So if you want to know the mechanical axis, you need to know where the femoral center is. So very easy way is to take the long X-ray. But even in Japan, to take the long X-ray is very difficult. So some reason is very due to the cost and due to the radiation. So it is very difficult. So, but if we know the angle difference between the anatomical axis and the mechanical axis, so we can insert IRM rod and the set the dial to the defined angle and cut. It looks easy, but to set the angle, how much we can set the angle is very difficult. the problem is that we need long X-ray and CT. It needs the cost of radiation. In addition, some amount of calculation error can occur because of rotation, image rotation. Yeah, for image rotation or image torsion. So, hi, Professor Mingaraba. Mingaraba. So it is not so easy. Yeah, of course, it can cause a technical error. For example, different endpoint point, and some patient has a very wide medullary canal. It can cause divergence of the IM route. So it can also cause the cutting error. It is not so small. Sometimes it's very large, big, sometimes the 2 or 3 degrees. So to resolve this problem, we can use a fluoroscope to identify the femoral head center. But it needs some radiation, and fluoroscope is very narrow field, and it can cause image torsion. So it is not so easy. And another solution is computer navigation. It's quite expensive. But currently, we can use the portable navigation. It's not so expensive. Today, I used the portable navigation because, Professor, hi. Yes, so in the near future, you can use this portable navigation. It is not so expensive and very, very convenient. But currently, the computer navigation is very expensive. And in addition, robotic surgery is more effective, but more expensive. So PSI means the patient-specific instrument. So to prepare the patient custom cutting guide, it is another good solution because currently so PCI the preparation of PSI is very expensive. But the recently we can easily use 3D printer. Maybe in your country there are many good engineers. So someone can make the PSI using the 3D printer easily, but also it needs CT or MRI. Maybe it is some difficulty, some problem. So instead of identify the femoral head, the fixed cutting angle is a very, very practical way. I always use the fixed cutting angle as 6 degrees for the Bayless knee and 4 degrees for the valgus knee. So this is the one for study from the journal Arthroplasty. Is this author studied around 500 patients to cut the same way. Fixed angle. Oh, hi, Brahma. Hi. Hi. But only the fixed angle 6 degrees is a quite simple way. No need to take X-ray, long X-ray or CT scan. But 86% patients come to the neutral area. Neutral area means HKA angle -3 to +3. It's very easy and the very promising way. So I always use this one. But now I currently move to portable navigation and kinematic alignment. Basically, kinematic alignment, we don't need the long X-ray. We see only the surface of the joint. Anyway, later I will explain about the kinematic alignment. So before the kinematic alignment, we need to understand precisely about the mechanical alignment. So what is the problem of the mechanical alignment? So we can make the conflict because joint line and mechanical line is different. So native joint line is medially sloped on the coronal plane, around 3 degrees in the medial slope. And in addition, this is very, very different among the patients. Some patients is almost perpendicular, and some patients more than 10 degrees. And this can cause conflict with prosthetic joint line and native joint line. So as I said before, so in the knee, soft tissue decides everything, the morphology and the kinematics. And even the joint line and the movement on the joint line. So if we change the joint line from this kind of slanted joint line to the vertical joint line, so everything will change. Ligament balance, kinematics, motion can be changed. So this conflict can cause stiffness and pain and instability, and then eventually dissatisfaction of patients. This is the one reason. It is considered to be the one reason for the dissatisfaction after TKA. So, but classically, the main surgeon is focused on the parallel and the equal joint gap. So this is the joint line orientation. Now, currently, joint line orientation, that means that this joint line, the relationship of this joint line to against the floor. In the short X-ray film, we can see every time but in fact, in the standing condition, this mechanical line laterally slightly, approximately 3 degrees, the lateral side. So in this situation, this red line, joint line comes horizontal to floor, parallel to the floor. So if we see this X-ray like this, so we can understand everything. So maybe this is this situation is very reasonable to weight bearing, weight loading, and the standing position, and while walking. So this inclination way for the weight bearing. So because this is very, very stable and reasonable for the standing and the walking. Okay. So we are now focused on the joint line. So joint line is very important. So understand joint line more precisely, we need to know the 3 kind of angles. One is lateral distal femoral angle, and that means that this angle is angle between joint line and this mechanical femoral line, mechanical femoral axis. So sometimes this is are slightly beta, around 0 to 4 degrees. And another one is MPTA, medial proximal tibial angle. And normally this is from 1 to 5 degrees in beta. So, but in the Asian patients, yeah. Okay, anyway, so there are two angles. So in the Asian patients, the MPTA is very beta, approximately 6 degrees in beta in average. I calculated this angle around 200 patients, and the average was around 6 degrees. And in addition, there are two angles, there are two lines. The distal femoral line and proximal tibial line is not parallel. It's some inclination, maybe due to the cartilage wear in the medial side and the medial way. And in addition, some patients have some bone loss for the tibial side. In this patient, this joint line convergence angle come bigger and bigger. Okay, so to consider this one, we can understand the patient deformity precisely. Okay, tomorrow I will talk about the mechanical alignment and further kinematic alignment. So, do you understand? Do you have any questions so far?
Yeah, I will send message to ask a question.
Okay.
Yeah.
Okay. Please send me a question.
Yes, Professor.
And I upload this video, this presentation to the YouTube, so you can see carefully. Maybe you will have some questions, because by explanation is not so good, insufficient. So you can see the later and carefully, and please send me the message. So it is very important. Many surgeons is focused on again. Classically, this problem is considered to be resolved, because mechanical alignment is gold standard. So only the cut the bone perpendicular, that is all right. Everything is all right. But now the answer is no. To cut the perpendicular is count the abnormal joint line. That is a very interesting. So roughly saying, many surgeons reconstruct this natural joint line, the slightly medially sloped joint line. That should be more natural, more kinematical. So before to move on to the kinematic alignment, but you can do the kinematic alignment very easily if you understand my talk. But for the kinematic alignment TKA, you need a CR component. Okay, because kinematic alignment needs the function of the cruciate ligament, the normal function of the soft tissue. So if you cut the PCL, the kinematics and the situation of the soft tissue is dramatically changed. So anyway, I will explain that later tomorrow. Okay?
Yes, Professor. Yes.
Okay.